Welcome to our webinar on inflammatory bowel disease and biologics, what the evidence is telling us. We would like to acknowledge the traditional custodians of the lands we are meeting tonight throughout Australia and recognise their physical and spiritual connection to land, waters and culture, enduring now and as it has been throughout time. We pay our respects to elders past, present and emerging, and you are all encouraged to know and connect with the First Nation lands on whom we're meeting tonight. So thank you for joining us tonight. My name is Professor Deborah Rowett from the University of South Australia, and I'm a member of the Therapeutics Alliance. And this webinar is funded by the Australian Government Department of Health through the Value in Prescribing program grant, and it's been developed with guidance of the members of the Targeted Therapies Alliance. And this webinar has been co-designed with the Gastroenterological Society of Australia. Some housekeeping points to start with to get the most out of this webinar. Please submit your questions through the Q&A function at the bottom of the screen, and we will endeavour to answer questions if there is time at the end of the session. Resources referred to throughout the webinar will be provided as a list with links at the end of the slides. This webinar is being recorded and the slides will be available on demand, available in a few days, and we'll send through the email link for that. Participation certificates will be provided for attending this webinar, and again an email will be sent with these available so that you can download them. There's also a short survey to complete at the end, and we would really value you taking a few minutes to provide your feedback. So I would like to invite our panel members to introduce themselves. Associate Professor Susie Connor.
Hi, I'm a gastroenterologist at the IBD service in Liverpool Hospital in Sydney.
Associate Professor Jake, if I can, Began, if you could please introduce yourself.
Hi, I'm Jake Begun. I'm a gastroenterologist at the Mater Hospital in Brisbane, where I do run the IBD service, and I'm also the director of gastroenterology.
Thank you very much. And Dr. Karen Luch.
Hi, my name is Karen. I'm a clinical pharmacist, background in hospital, specialized in oncology for a while, but also clinical education. And I'm currently working with the University of South Australia on behalf of the TTA, establishing evidence summaries around biologics in autoimmune diseases.
Thank you very much. So thank you for those introductions, and we look forward to your presentations tonight. We have a number of people that are joining us on the webinar, which includes gastroenterologists, IBD specialists, IBD nurses, pharmacists, both hospital and community. So welcome everyone to this webinar tonight. So just moving then on to the outline for the webinar, that we will be discussing the choice of biologic for first and second line biological therapies, the use of biologics in combination, the use of biologics in combination with immune modulators, the use of therapeutic drug monitoring to optimize therapy, and then also when to consider dose escalation and dose de-escalation of biological therapy. So I think it's going to be a very interesting and informative session tonight. There will be a discussion of these evidence summaries that have been developed on behalf of the Therapeutic Targeted Alliance, and these resources have been developed to underpin the design and delivery of a range of the services and also the resources that have been developed for gastroenterologists and patients with inflammatory bowel disease. Throughout the presentation, there will be, some discussion where there will be use of abbreviations, and I suppose it's a fairly acronym-rich area that we've got, and so these are just some of the ones to highlight, particularly around the drug names, but also the societies there on the right-hand panel. So perhaps without too much further discussion of the introduction, I think it will be important to commence this, I suppose, the evidence summaries that have underpinned this evening's session. They're about providing you with the most current up-to-date evidence, really right up until May this year, when the searches, the gathering of the evidence, the best available evidence to inform these evidence summaries in the discussion tonight. There are areas of uncertainty, and these are some of the areas that we're going to focus on tonight, is where there are still some uncertainty in the evidence, and that has been identified by the gastroenterologists. So I think might move and hand over to you, Karen, to begin presenting tonight.
Whoops. Sorry, I can't. Can you change me back, Deborah?
Yep, sure.
I don't, sorry.
There we are.
Yep, line of therapy. Thank you, Deborah. I may have to ask you to move the slides because I just can't see the arrows at the moment.
Okay.
So thank you everybody for joining. So we're talking about line of therapy of biologics when they're needed first. So where to start, where to move on to, talking about evidence for first and second line choices of biologics. And this is with a focus on moderate to severe ulcerative colitis and Crohn's disease. We have included guideline recommendations on these treatment choices, but also will summarize some of the pivotal randomized controlled trials. And in the absence of comparative trials between biologics, a few network meta-analyses have recently been published. And bar them establishing that infliximab is probably the most effective biologic, it's for other agents a little bit more conflicting. We go to the next. Thank you. And we're starting with moderate to severe ulcerative colitis, and the guidance from ECHO and the AGA, and they're the two professional organizations I will be quoting most, currently recommend infliximab and vedolizumab as the first-line therapy. And to give us a little bit of an idea how effective these agents are, with all the reservations that, you know, we can't really compare these trials because they would have had slightly different patient populations. But I actually looked for the rates on clinical remission in all the pivotal phase 3 studies and tried to express them as numbers needed to treat. And we can see that for the numbers needed to treat for induction, infliximab and vedolizumab indeed look sort of to be the most effective, also in maintenance, and the others are listed below. And I've also, if anyone wanted to go back and trawl through supplementary files and trials, I listed the trials on the slides as well for you later. And then if you go to second line therapy, so that is usually when anti-TNF alpha inhibitors have failed. So that's usually what has been studied. Only I think the evidence around other agents is developing. And currently ECHO and AGA recommend either an alternative TNF inhibitor. And we're looking also later a little bit, you know, how you can determine whether to switch within class or whether to go to different agent. And for colitis, that would be then vedolizumab or tofacitinib. And then going to those pivotal studies there, we can see the number needed to treat for induction now becomes a bit bigger. And that is sort of a common picture across all of them, that usually as a second line agent, they're not quite as effective to induce remission, whereas the number needed to treat for maintenance, once somebody responds, they stay pretty much the same. And we're moving on to Crohn's disease. The tricky bit is really when you've used vedolizumab or tofacitinib as first-line agent, there's really sparse evidence to support any choice of second-line agent because they haven't been long enough around to really then see what happens if people lose response. And so the general guideline there is that infliximab is probably the preferred option because it's generally a very effective agent. And there's some evidence, which we may just call moderate, from observational studies that infliximab works after vedolizumab failure. And there's also some data for golimumab after other anti-TNF inhibitors or vedo. And then now moving on to luminal Crohn's disease. And Again, ECHO and AGA recommend infliximab, particularly in combination with immunomodulators as first line, but also adalimumab. And the AGA, with their latest update, which was just released in June this year, also added ustekinumab to the first-line therapy. And same thing, so I've listed the number needed to treat from the phase 3 studies for induction and maintenance, and we can see that there really isn't much between infliximab, adalimumab, and ustekinumab. And when we have to use a second-line biologic in Crohn's disease, Deborah, if you just move it, then again, there is, like in colitis, not that much guidance on efficacy, but when, ustekinumab and vedolizumab have failed as first-line therapy, and probably falls back to infliximab, and the numbers needed to treat are also listed. And, this is for the people who already had a biologic failure versus those who were biologic naive. And that should bring me to handing over to Susie and Jake and Deborah.
Yeah, thank you. Thank you very much, Karen, for setting the scene there. But there are some gaps and uncertainties in the evidence as you've presented, and particularly, the evidence guiding which agent to use after failure of some of the first-line therapies. So perhaps I could ask Susie first, how do you translate this evidence then into your practice?
You're mute.
No, that's okay, sorry. So in terms of first-line therapy for Crohn's disease, I would use an anti-TNF agent or ustekinumab first. And there's been a recent a recent abstract outlining the Seaview study, which compares luminal Crohn's disease patients with adalimumab versus ustekinumab, and they were found to be equivalent. And so given those results, I essentially, in terms of first-line therapy, concur with, in terms of Crohn's disease, what Karen has said. And in terms of ulcerative colitis, in terms of first-line therapy, the choice would be vedolizumab or infliximab, as you've said, and as she's also mentioned, the VASTI study did show superiority of vedolizumab over adalimumab, but did not compare infliximab. Yeah. So I think in terms of first-line therapy, they're the two choices I'd make, and I would base it then on discussions with the patient and other features regarding the patient, such as, pregnancy and extraintestinal manifestations, which we'll be discussing a bit later, and, ability to use immunomodulator therapy and, other factors like that. In terms of second-line therapy, I think the first thing really also is that I, in terms of the first therapy, try and use it as well as possible. And we'll be going through some of those other features shortly, but I think really important that when you use a therapy, you use it well, whichever it is. And then in terms of second-line therapy, again, I think it comes more to patient factors because the evidence at the moment is not, as you've mentioned, it's not there yet. And so then I think it comes down to, again, then patient factors and sometimes I was going to say like a flip of the dice, but it also depends a bit on other factors, which we're going to discuss a little bit further down the track in terms of, anti-drug antibodies, et cetera. I don't know, Jake, I'm sure want to say something as well.
Yes, please, Dr. Pigan.
Thanks, Susie. I think that was a great summary, and I suspect our practice patterns are very similar. As you say, every patient is a unique individual, and so there's individual decisions that need to be made based on the patient in front of you, but it is nice to have in the back of your mind the overall comparative, roughly speaking, efficacies of these agents, so that you can have an informed discussion with the patients. And so I agree completely with your practice patterns. That's mine as well. I will just add one thing, which is in addition to the considerations you mentioned, which we'll talk about, another very practical thing is where the patient is located and whether or not infusions are practical or not in terms of what medication you choose.
And I think another thing on the terms of patients is also the type of, with respect to that, what type of modality in terms of subcutaneous, intravenous, oral, because that will, based on location, also I think adherence of patients, which you all know some patients are less adherent than or compliant than other patients, and therefore those sort of discussions need to be had with patients around, the importance of taking the drugs. If you don't take the drug, you'll develop anti-drug antibodies and the drug won't work. So Yeah.
Just one of the things that you both had highlighted, and I know that you mentioned that we were going to be talking about special considerations, particularly, for example, pregnancy. But what about other comorbidities that people might have and that influencing your treatment choices?
I can mention a couple. Which one common thing as we get to be older and older patients, which of course is a consideration, is comorbidities, including cardiovascular risk factors, which might be something. For example, TNFs are relatively contraindicated in people with New York classification for heart failure, for example. Patients with demyelinating conditions like MS, then anti-TNFs are also contraindicated in that case. And malignancies, which is something that we worry about too, especially up here in Queensland, where the sun is usually shining. Melanomas are a big concern, and in that case, we often shy away from anti-TNFs in the setting of melanomas, for example. So you do have to think about those medical comorbidities.
I think also in following on from that is, I mean, obviously you have an increased risk of melanoma, a small increased risk of melanoma with anti-TNFs and lymphoma then with thiopurine. So if a patient, and probably it's the same with methotrexate, we just don't have the data in methotrexate in terms of lymphoma risk as you get beyond the age of 65. And so then you may be less inclined, for example, to give an anti-TNF agent because you do need to give it in combination with an immunomodulator. And so you might be more inclined than an older person to go with a biologic, which you don't, which it seems at this stage is there's less necessity for an immunomodulator in combination with the biologic. So you may be more inclined then to go with a gut-specific biologic such as vedolizumab in an older patient, or ustekinumab, which actually does also have a very good safety profile. And we've also got the IL-23 drugs coming up as well, and I think they're going to be really also, I think, have very good safety profile, it looks like. Another thing I think we should also mention that there are quite a number of head-to-head studies coming, looking at comparing two drugs. So actually a lot of the drugs, the registration trials now in terms of, guselkumab, risankizumab, there's the new IL-23 drugs, they are actually, the trials are also comparing another drug, for example, ustekinumab. As a comparative drug. So we are going to be having more head-to-head trials in the future, and we actually have a lot that are in process at the moment, which will help us in those decision making, particularly with comparing the newer drugs such as the IL-23s.
No, thank you very much for that, Susie. I was going to ask you about what's coming, and if there are some more head-to-head studies. So, thanks for outlining those. That's really important.
I think there's about like 10. There are 10 currently. There's a publication in Nature Reviews last year that outlined them, and Jake and I are talking about them coming up. They've all got their own little acronyms, Jake and I, the Sequence and Vega and Galaxy and Vivid. So we're going to be seeing a whole lot of them in the near future.
And I suppose that's what's really important, isn't it? Is that the reason why we need to keep up to date is because this evidence base is changing, and there is a lot of emerging new evidence. But I think some of the points that you've raised around the comorbidities are really important. Some of the challenges around the second-line therapies, but also importantly, those conversations with patients about those where there is uncertainty, particularly for the second and third line choices that you're making. And so having those.
Sorry, I was just going to say one other point. Sorry, I didn't mean to interrupt you. Sorry, was that another thing which I think is the Seaview data has shown us is that we're talking about using the drugs well. Is that the Seaview results are very, very good, like up to 65-70% remission. And shows if you use it. And so I think also it's really interesting, those patients where the drugs were used early. Yes. And I think also using drugs well, I think is also really important. So they were comparable, the two drugs were comparable, but it's also around using them well when you use them.
Yeah.
Sorry,
thank you very much.
Sorry.
That's it. No, that's a great summary point, and probably one of the ones I wanted to make was, it is in conversation and discussion with the patients, because if they don't use them well, then you're not going to see the benefits. And so it's that shared decision making with the patient is really very important. But perhaps we can move on to some of the more I suppose, special considerations for these diseases. And Karen, I'll hand back to you.
Thank you. So one of them, we talked about luminal Crohn's disease before, and now we look at fistulizing Crohn's disease. And really at this point in time, most guidelines would recommend infliximab or adalimumab in combination with an immunomodulator, and mainly because that's where the evidence is. They have been more widely studied than any other agent in those situations. And when they fail a second-line therapy, there's really no evidence to establish the preferred treatment. So probably you could use adalimumab after infliximab failure, or ustekinumab once TNF inhibitors have not worked. And this is probably the one scenario we're going to talk where you really want to make sure they work well and you get the best out of the biologic. Yeah. There are other special situations and comorbidities, and probably around about, I mean, the stats vary, but let's say around about a third of people with IBD also would have extraintestinal manifestations, other autoimmune conditions. And the rule of thumb really is for first line there, infliximab, and simply because it is actually across all autoimmune diseases like psoriasis or rheumatoid arthritis, it always sits in the top quartile of effectiveness, which is not necessarily the case for others. And then followed by adalimumab. The other ease with those two is that they're actually registered, licensed, and PBS listed for all the other conditions as well. If somebody has psoriasis, you may also be able to use ustekinumab, but I think with extraintestinal manifestations or other autoimmune diseases, you really then prioritize what you want to treat. For example, ustekinumab isn't as effective in psoriasis compared to infliximab. So that's why I just left infliximab, adalimumab up there, because they're a good rule of thumb first-line therapy to go to. In pregnancy and breastfeeding, there's always that caveat of saying only if the benefit outweighs the risk, keeping in mind that the risk from uncontrolled IBD to pregnancy is not insignificant. And the first-line biologic therapy there is just because we have the most experience there for infliximab and adalimumab. But there's also now evidence evolving that vedolizumab and ustekinumab seem to be safe, and alternative TNF inhibitors as well. And with that, we're moving on to combination therapy, which can be one strategy to really make biologics work. In terms of randomized controlled trials, the combination really only has been tested for efficacy and safety with infliximab and adalimumab. We have to keep in mind that all efficacy trials have a proportion of patients who start the study taking concomitant immunomodulators. And interestingly, they're always reported at baseline. I have not found a study yet where I could really dig out how was it at week 52, how many were still on an immunomodulator at the same time. It's not that easy to find that data. There's also some evidence now coming from observational studies that, for example, in combination therapy with infliximab, a reduced thiopurine dose is equally as effective as the standard dose. And that may be getting around some of the adverse effects that people experience and then stop their thiopurine because of them. So we know from the evidence that definitely infliximab in both colitis and Crohn's disease should be combined with an immunomodulator at least for some time to reduce immunogenicity. There's a definite no contraindication for tafasitamab and immunomodulator combination. And then there's a maybe for up to 12 months with other BD-MARTs, and we discuss that on the next slide. And there are quite a bit of uncertainties here. So it's interesting how professional organizations and guidelines sit on the fence in that one very often. So their recommendation generally is if it's high risk, maybe if it's a second biologic and you're really concerned that that may fail, then up to 12 months combination therapy could be considered. And it all rests on the premise that similarly to the observations we had with adalimumab, that immunomodulators will increase drug serum levels and reduce the formation of anti-drug antibodies. And for example, there have been findings for ustekinumab that it may be beneficial to add them if patients are slow to respond to treatment. And although vedolizumab and ustekinumab definitely have lower antibody formation, it's still, around 4 to 5%. That's 1 in 20. So although the clinical relevance of antibodies with those drugs is not quite clear, it may be worthwhile to consider then in high-risk situations combination therapy. So, and
So we're actually going fairly well to time, Karen, and that gives Susie and Jake a bit more opportunity to share with us, really what does this look like in practice? So thank you very much for, keeping to time, because it's also, we've got this evidence, but again, perhaps starting with you, Jake, this time, under what circumstances would you not use an immune modulator in combination with a biologic?
Thanks, Deb. That's a great question. And my own practice in general is to continue immunomodulators when I commence a biologic therapy, and to only consider stopping it in case that I have achieved clinical remission and also hit my endoscopic targets of endoscopic healing. So in a patient who's in clinical remission, I'm pretty confident that we have good control of their inflammation objectively. Then we'll have a discussion about the pros and cons of stopping it. I also sometimes will utilize therapeutic drug monitoring in this situation to ensure that they have adequate levels of their biologic prior to doing that, and also follow up after stopping immunomodulators, since the immunomodulator drugs have a couple of effects. One is an anti-immunogenic effect, so prevent anti-drug antibody formation, but they also have other effects on the pharmacokinetics of these molecules that are not completely defined, but certainly well described in the literature. So I think it's important to keep an eye on things if you do make the decision to stop immunomodulator therapy. And as Susie outlined before, there are risks with these drugs, and particularly in certain populations where we're concerned about skin cancers, lymphoma, and other complications, it's a very reasonable thing to consider.
Thank you very much. Susie, thought...
Yeah, I would support what...
using the combination, and what does your practice look like?
Well, I practice similarly to Jake in terms of, even though, there is lower immunogenicity with in ustekinumab and vedolizumab, most of the patients who get to the point of biologics, I would define as a high-risk patient, because that's what we're giving them, biologics, not high risk, but we want to get them well quickly. Yeah. And so normally I would give them the immunomodulator like Jake until they're in remission, they've got endoscopic healing, or as good as I think it's going to be. And then we have a discussion, so normally around 12 months. And then again, have a discussion about stopping them. But I think the other really important point is that I actually normally just halve it first, and then with a 6-GGN of around 125 with a thiopurine, and then just watch them for a bit longer, so another 6 months. And if their fecal calprotectin remains normal and their drug levels remain therapeutic, then I stop it completely. The only reason I do that as well is because, as Jake mentioned, there are some patients, although not many, that actually do. The thiopurine actually works not only in its effect on the biologic, but also there does seem to be another effect related to disease control. And I've certainly had quite a number of patients who've flared subsequent to stopping their immunomodulator. So even though it's a minority of my patients, and we know that from all the data, it's still, there are some patients that the immunomodulator is doing something as well. And so the main thing is to watch after you stop and make sure the patients remain well, so that you don't, it's always about monitoring and watching whatever you do. See what you do, and then make sure it's worked or hasn't worked, and then move on, basically, based on that. And I think obviously, risks and benefit there's always the risks with the drugs. There's also the risks of disease getting out of control again, which we never need to forget. Yeah.
And one of the questions that's come up in the chat, which both of you have touched on a little bit, is the risk for lymphoma. But the question that is included in the chat is the risk of lymphoma in young males still a good reason to stop azathioprine in those patients?
Yeah, so I'll just quickly touch on that to start with, and then Susie can comment as well. So when we talk about lymphoma, we talk about the overall risk of lymphoma, which is about a increase in relative risk, an absolute risk of maybe 4 in 10,000. And that's usually a diffuse B-cell lymphoma, which is a fairly treatable lymphoma if it occurs. There's a second type of lymphoma that's much rarer and mainly in young men, but it can also happen in women, that's related to thiopurine use, which is hepatosplenic T-cell lymphoma, which is a very aggressive lymphoma with, it used to be near universal mortality. There are some case reports now of successful treatments with bone marrow transplantation, et cetera. But this is a dreadful complication of thiopurine use, mainly in young people, although not exclusively, and often quite fatal. So in this case, it is something to consider the risk. The absolute risk is still very low, 1 in over 10,000, 1 in 20,000, something like
Mm.
that. Risks are very hard to estimate when there's such low cases. And the risk is 0 in the first 12 months of therapy. So you have that window of opportunity. And once you get out to 2 years of therapy, I think that if you are risk averse and if the patient's risk averse, then that's a good conversation to have about avoiding that complication and thinking about agents where you can avoid thiopurines.
And that's sort of we're talking about young males, talking about under the age of 35.
And it was that specific type of lymphoma
If they
that
have
was
hepatocellular T-cell lymphoma that they would be talking about. And the reason is because the risk benefit, I mean, the fact is that it's in most cases fatal, and that's why, although the actual risk is very, very, very low.
Yeah.
And methotrexate doesn't seem to have quite the same risk with the
No, it doesn't. So in terms of using combinations, we often use methotrexate for that reason in young males instead, in combination therapy.
So, yeah, thank you both very much. And as I said, we're making, we've got good time and being able to respond to the questions. And one of the other questions, which I won't, I'll come back to the person who's asked that in the chat around administration of infliximab. But I wanted to give us enough time then to perhaps move on now, Karen, to the discussion around escalation and de-escalation, because I think this has been an important area as part of that research and the evidence summary. So I will move the slides on to that. So over to you, Karen.
So probably in your experience, you have seen that it's sort of from the data we know approximately 1/3 of patients who are prescribed infliximab or adalimumab, that their dose may have to be escalated to achieve or re-induce maintained remission. There was a question asking about whether it's better to escalate the dose or shorten the dosing interval. And we discussed that and thought really it's also around preference of the patient. And generally, it's probably better for infliximab to shorten the administration interval rather than escalating the dose. They both work. There's really only a very small margin between the two strategies. It just depends whether somebody can come back for more regular infusions. And for adalimumab, it will just be the shortening of the interval. There's very little data so far on dose escalation for other biologics. And the question then is, once you have escalated the dose and remission has been achieved and it's been sustained on that high dose, whether you come down from that dose, de-escalate the dose. And we're going to look at the evidence around that on the next slide. And it's a bit, this is one of those gray areas. There are actually a lot of observational studies who have used varying parameters guiding and determining how they de-escalate and what strategies they use. And this is where the net really has to be cast a bit wider, because if you combine the evidence from these observational studies, which usually would, if you go to grading of evidence, would sit on the weak end of evidence quality. But if you combine them with studies or the randomized controlled trials that used actually TDM-based dosing, and also those that used monitoring of fecal calprotectin in relation to disease activity, then we can actually come to some conclusions which are on the next slide. So this is really bringing all the evidence together from quite a few different scenarios and studies. If you go to that, Deb. And so we can probably with good confidence then say that approximately 2/3 of patients will not relapse when their dose is de-escalated to the normal standard regimen after previous dose escalation, when they have been in deep remission for 12 months. And that aligns very well, again, with the AGA, for example, their Crohn's guidelines now who say, you can trial de-escalation after 6 months of quiescent disease. If then serum drug levels are maintained within the recommended therapeutic range, or at least above the minimum level, and fecal calprotectin is within the normal range before de-escalation and is maintained within that normal range after de-escalation. So that seems to work in about 2/3 of patients, so which then says, the reverse conclusion is in a third of patients that doesn't work very well, but the majority of those can be then caught again with escalation. It's only a small percentage where you de-escalate and they may then not regain remission with a successive dose escalation. And at the same time, we have to keep in mind that there's always this background rate of loss of response over time, particularly in patients treated with TNF-alpha inhibitors anyway. And, the evidence we're drawing on here really didn't have control groups. So those might just be the normal attrition rate of TNF-alpha over time. Next one. And we mentioned therapeutic drug monitoring as part of a de-escalation strategy. And usually when we talk about TDM, it's monitoring serum drug levels and anti-drug antibodies. In practice, anti-drug antibodies are often only measured if serum levels are at a particular level, and that may vary depending on the lab you have access to. Next one. So again, because infliximab and adalimumab have been around for so long, we have sort of therapeutic ranges established for those two. For everything else, it's more exploratory. And so there are some recommendations for, let's say, minimum levels. I know that some tertiary centers make, but if you look at the evidence that is there, the range is actually quite wide in terms of what could be recommended as a minimum level to which correlates reasonably well to attaining remission. So at this point in time, most guideline bodies wouldn't really make recommendations. And if we go to the next slide, we would have a summary of what various organizations recommend at this point in time. And as you can see, it's mainly around anti-TNF inhibitors. And the slides will be available, so we won't dwell on them for too long and move on. So there are two different scenarios on where you could monitor. So the first one is really around if somebody is unwell and has active disease, so it's reactive to disease activity. There's quite strong evidence now that it supports decision-making in terms of what you do next, and more indirect evidence that it actually influences clinical outcome. So we're mainly talking about if somebody experiences secondary or primary loss of response. The second scenario is proactive monitoring, which would be routine TDM if in quiescent disease that may support clinical decision-making, but there are actually randomized controlled trials that have been performed. Another one, the NORDRUM, I think, is in process. And there's really no evidence that it influenced the clinical outcome. But there may, and I'm sure Jake and Susie will talk about that, there may be merit to obtain a level after induction just to make sure that a target level has been reached, for example, to reduce immunogenicity of anti-TNF inhibitors. The same could be said for drug monitoring during maintenance. And particularly if you want to step down from combination or escalated biologic therapy, it's probably worthwhile to know that there is actually a therapeutic level before you change anything. And there are quite a few algorithms out there which can guide the decisions based on TDM. This is from the BSG. Again, it will be available to you. GISA has a similar one. And I hand over to Deborah, Susie and Jake to discuss.
Do you want me to move off that slide, Karen?
Sorry?
Do you want me to move off that slide?
Yeah, no, so we're on the discussion. So if Susie and Jake probably want to comment on when they do them levels.
Yeah, thank you very much, Karen. And I think that is right as we move into, okay, we can do this therapeutic drug monitoring, but Jake and Susie, how do you use it in practice and what does it look like from your perspective? Jake first.
That doesn't matter. You go first, Jake.
I think we are slightly different in our approaches to therapeutic drug monitoring. So my general approach to TDM is usually in a reactive manner. So I'm certainly reaching for TDM in patients who have either failed to respond to therapy that we've initiated or had a primary response and then a secondary loss of response. And that's generally so that I can inform my decision about whether they would be appropriate for dose escalation if they have low levels, or if they're forming anti-drug antibodies, whether they would be a switch in class or whether or not they have active disease in the setting of therapeutic or super therapeutic levels, in which I would consider a change out of class. So in a reactive scenario and approach, I think I'm very comfortable with interpreting the results. I don't use it very often in a proactive way. The one exception would be on patients who I'm considering de-escalation of therapy, either dropping the immunomodulator or even going on a drug holiday from the biologic. And there I also find TDM to be useful. For example, if we have a patient who's in a good clinical remission with endoscopic healing, who has very low drug levels, you're probably going to make no difference to the disease course if you stop the biologic at that point. And similarly, if they have very high levels, I feel more confident if I'm thinking about stopping the immunomodulator in that setting. I think Susie, however, uses more proactive drug monitoring than I do, so I might let her comment on that one.
So in terms, I think everyone's sort of on the same page about reactive monitoring. So in terms of proactive, so I would also, like with Jake, if I'm going to consider dropping an immunomodulator, I would like to see the biologic in a therapeutic range with the anti-TNF therapy. So generally over 5 with infliximab or adalimumab, and before I'd stop the immunomodulator and obviously have a normal fecal calprotectin. And similarly, you know, in terms of when you're thinking about dropping an escalated dose, and having the patient actually obviously in remission as well. I do also check proactively. We do levels at week 14, so at the end of induction, and the reason for that is to make sure the patient we don't do it so much although we do sometimes do it in patients we're very worried about with ustekinumab and vedolizumab, but it's really very hard to know how to interpret those levels at the moment. So I'm talking more specifically about anti-TNF agents. So in patients with luminal disease, our unit would normally check the level at week 14 to make sure that it was therapeutic and they weren't developing anti-drug antibodies. The level was low. And in those contexts, then we might think about, we watch those patients very closely, and if they're already starting to develop anti-drug antibodies at the levels that are, for example, under 3 with infliximab, we'd be very keen to think about dose escalation. If we don't then we would actually dose escalate. The only other time we do think about it as well is with acute severe colitis, and we're sort of enrolled. There's a very good study that's been going on, Australian multi-centre study run by Peter de Cruz from Austin Hospital called PREDICT, and PREDICT using, I think this will actually inform how we do dose in acute severe ulcerative colitis. So I just wanted to say that those results will be out soon. But certainly, you know, we do worry that the levels probably do need to be higher during induction, and sometimes we do use, when the patient can't go into PREDICT for whatever reasons, we have used infliximab levels in that context as well.
Susie, may I sort of, with fistulizing Crohn's disease also, there's some evidence that high levels are better. For where would you?
So we'd try to aim for a level. So we're going to be doing a study looking specifically at that. So we're about to do a study looking at called Proactive, looking specifically at fistulizing Crohn's disease, and that's going to be like the sister to PREDICT, but and that's going to be an Australian multi-centre study, which is about to start, looking at proactive, like having 2 arms, one where the patients get aggressive levels, aggressive infliximab and level testing from induction versus standard dosing. So no patient at the moment is going to not be on that trial for us. So then I'll be able to tell you that in the future what we do based on trial evidence. So those results hopefully will be out in 4 years' time. 3 years' time. In the meantime, what do I do? Well, I mean, that will inform us in some, obviously from a randomized controlled trial, we'll be able to inform us. But now, in terms of fistulizing disease, we do check levels at week 14, but again, we're not necessarily aggressive about getting the level above 10 actually at all, because we know that in maintenance one needs a level above 10, but the thing is it's never been done in a proactive way at all. And so I think we can't really make any comments about that. So that's why we're doing the trial, basically. So again, we just watch them clinically and just see.
Yeah, I think
it's only if the levels are very low, like we're talking like 2, 1, 3, that we might be more anxious. But we're not pushing it up to levels above 10 at this stage, no way. in that context with fistulizing disease. Because the thing I think also to remember is none of these trials, the only trial that's really been an absolute positive study is Palette, and that was from induction. And otherwise, every other trial, Taxit and Taylorix have been negative studies. So, I mean, it's hard to justify proactive testing, except I think, in the patients where you've got lower levels around sort of week 14. And obviously when we get predict and proactive, we'll be able to make more sound conclusions or not. I don't know if you want to speak any more to that, Jake.
Oh, I was only going to emphasize the point that all of these associative studies are just that, associative studies, and it can be difficult to assign causality in those cases, unless you have, as you say, the RCTs and prospective studies, which were really lacking. The other thing I would say is that in those prospective studies, the clinical decision-making to dose escalate based on clinical criteria or on objective markers of disease activity show almost equivalent efficacy in terms of getting control of disease. So in your example for fistulizing disease, I think that being driven by the clinical activity of the fistula and dose escalating might be just as informative. And so we'll see.
Oh, well, that's exactly what we'll see. I think the other thing about that trial, though, is we're going to be having very aggressive surgical management. So we may, in fact, be shooting ourselves in the foot by doing that. But remember that, that sort of trial is also very important to understand, how we manage these things. So I think the other thing is not only about drug levels, it's about how you manage the whole patient and looking at all the other things. The drug levels are only part of that picture.
Yeah,
I think it's so.
Yeah, and I was going to ask you about that. I mean, Susie, you've already answered my question about what's coming. But the assays, there can be variable levels as well, and again, it's that interpretation, isn't it, of the levels? I think you were highlighting that it's not an exact science in terms of using.
Well, what I was going to say was more about the point I was trying to make was around association. So, they're all around. You can look at mucosal healing and correspond it to levels, but it's all cross-sectional studies. It's not prospective. So if you get, if you put, 80% of patients, if you get their level above 20, if it's luminal Crohn's disease, 80% of patients are going to get healing. But, how hard do you want to push that drug? And but that's all in cross-sectional studies, not been done prospectively. And I think that's the point we're trying to say. And the drug level is only one part
That's right.
of the thing. You've got to look at it as all those different things together. And it's not like an absolute drug level you should be aiming for, because there are some patients who have a level of 3 and who have, with infliximab, who have pristine mucosa and absolute healing. So that for whatever reason, there's something else going on in those patients.
Yeah. And I'm going to come to questions shortly, but there's one at the moment in the chat which sort of would draw out some of that discussion. And the question is, in a young male, if their anti-TNF levels were therapeutic, but the patient had loss of response, is it reasonable to switch to a different class of biologic due to the risk of lymphoma, or would you shorten the interval first?
Depends.
Who would like to take that?
Do you want to speak to that, Jake? I'm not.
You were speaking before about the risk of lymphoma in young men, speaking more about thiopurines. And so perhaps the question is about the fact that if they're on infliximab and you're starting to get breakthrough symptoms, that you're really wedded to combination therapy, and should you be switching classes so you don't need it? I'm inferring on this question here. In general, I would say that we do push the dose of our medications before totally abandoning them, because we have limited options in the field of inflammatory bowel disease. And before we burn a biologic, I think we're inclined to want to push the dose all the way. But that being said, I wouldn't wait forever when you do that. So for example, patient failing infliximab on standard dosing, had an initial response, secondary loss of response, have levels, no antibodies, I would push that dose, but I would probably only give it 3 or 4 months. And if I don't get where I need to be in terms of my targets at that point, then I'm having a real decision about switching. And if they were good levels and I had pushed the dose, I'd be thinking about switching out of class.
And I think also, Jake, in terms of good levels, and if the level's already above 10, say, then and they're, then I think you should be moving on. We're talking about, if you're talking about therapeutic levels, there's a range of therapeutic levels. Okay, and I think once the level's already, okay, maybe above 12 with infliximab to be, if you look at all the data, we've defined it in luminal disease at 6 to 10. You might push it to 12, but above that, there's no point continuing to dose escalate. It's not going to do anything. The drug, if you look at if we just go back to the previous slide, that mechanism of action is not working you need to move on to another mechanism of action. So what I was trying to work out is when someone says therapeutic level, I think internationally, if the level was say 5, for example, infliximab, you would dose escalate. And then as Jake said, and then recheck the level. And then if the level say 10, 12, and they're still not getting any better, you need to move on. Don't just keep dose escalating because it's not working.
Yeah.
Basically. And if it's really above 10 and they've got active disease, you need to move on, basically.
I think that's a really important point as well.
Yeah. You don't keep making the same mistake.
Absolutely.
Yeah.
But then they'll feel also to make sure that they take in all those sort of things, but obviously the levels how they should be. But
I think the critical thing is not to like dose escalate, wait 6 months and reevaluate. These are
no, exactly.
regularly and
we have actually also had issues where you need to actually make sure when the patient's actually taken the drug level. So, we've had patients that take the drug level the day after they've taken, for example, their Humira. I mean, you should have steady state, but even some work that Mark Ward's done, it should be really close to it should even be with the subcutaneous drug still as close as possible to just prior to the next dose. And obviously with infliximab, we've had patients take it halfway through the cycle, not just before the next dose. You need to make sure it's actually a trough level.
Yeah. These are really practical points, and I think that they're really important. One of the earlier questions that was asked actually was around, do you have a preference over subcut or parenteral infliximab? I might just go back to that.
You okay if I start, Susie?
Yeah, go for it.
Yeah. Is there evidence for IV over subcut?
So we are very fortunate that subcut infliximab has just been approved by the PBS, and we now have access through that. We also have had access for the last few months through the product familiarization program. It's only available right now as Remsima. They're the only approved subcut infliximab. The standard dosing for that product is to get 2 IV doses and then to switch to subcut. That would be the standard induction, or to switch people over who are in maintenance when they would normally be due for their infliximab infusion, to switch them over to subcut, which is 120 milligrams every 2 weeks for all those out there listening. So the question, which is the way to go? When you look at the trials of subcut infliximab in all indications and also in inflammatory bowel disease, what you find is that the serum levels that you're getting of the subcut preparation are actually significantly higher than the typical concentrations you would get from standard dosing with IV infliximab. So typically you're getting levels that are above 12 and closer to sort of 15 to 18 actually with the subcut preparations, and also less variation from peak to trough, which is probably also going to have an effect both on immunogenicity and on activity. So my own feeling is that there are a lot of patients out there who would love to have a subcut option, and it's going to be very safe to switch our patients who are in stable remission over. I think that we'll be gaining experience in terms of inducing with IV and then switching over to subcut after just 2 IV doses. That I would like to get some more experience with myself, and I suspect that it'll be select patients that were using that approach in the beginning.
And I suppose I left it till now when we're talking about TDM, was also about interpreting the levels, and using TDM as part of this. You've kind of touched it, you might expect to be using subcut versus IV. But Susie, if I can go to you with that question, which is there a preference from your perspective in terms of subcut versus IV that's different or that's similar to Jake?
Sorry, I was just going to say, I think we're lucky we've now got it available, and we're all very interested in getting some experience about it. And the trial data is exactly what Jake said. So we're now. I'm going to be less inclined to give it in people that are already on dose escalated therapy. We're not going to be doing that. It's going to be people that are on standard therapy and switching them over to subcut, because I think it is the levels being maintained throughout the cycle, and actually higher levels is reassuring, and then the trial data shows that they're equally effective, so IV and subcut. And obviously there are some patients that just be very happy to have subcut, and particularly in southwestern Sydney at the moment we have to have a COVID test before you go to get your infusion. It'd be very nice to be able to have it at home. So absolutely.
No. Well, thank you very much. And we've got a number of questions that we've been asked, and I might try and address some of those questions if that's possible. And one of the questions here is, and I think, Jeannie, that's been perhaps answered already. For me, would you recommend a full biologic blood test? Again, particularly in young males, is the question. And would you check EBC serology at that time?
I didn't hear that question. Did you hear that, Jake?
I'll read it again if that's okay. Would you recommend a full biologic pre-screening blood test set prior to starting thiopurines? And would you check EBC serology, particularly in young males?
So yeah, I generally perform a full biologic screen when we're starting immunomodulators, mostly because there's a good chance they're going to end up on biologics when they come to it. So that's one good reason to do it and get it out of the way. But also the viral serologies are important. I saw that there was a question about EBV serology and what to do about it. I think the concern about an EBV negative patient going on thiopurines is if they get a primary EBV infection, they can get quite sick and get HLH sickness, which can get people very sick. I think the important thing, I still do use it in EBV negative people and kids and males even. The key thing is to stop the thiopurine if they get a fever and symptoms of glandular disease. That's the important thing, not to continue on the thiopurine, because that's when you run into trouble.
Yep.
Yeah, and I think the other thing also, so we also check in our centre, we also check EBV serology. And the other reason also is at exactly that point, then we certainly use it. But then to say, if you get a fever, you stop it. If they've got any of that glandular, young 18, 19-year-olds that are having lots of pashing and kissing, that you stop it. As soon as you stop it, that's fine. So we certainly use it. The other thing also, I think, in terms of just the whole issue of if you get the vaccination screen done before you start a patient, then you have the opportunity to vaccinate patients before they start on immunomodulators, and particularly things like varicella. I'm interested as well in some patients not having immunity to measles or mumps. And I think, if you've got the opportunity then to get them vaccinated, and if you've got the opportunity to not, to get on with that vaccination prior to them being on a lifelong potentially of modulator therapy, I think we take that opportunity at the beginning. And so that's what we do initially. We, in fact, get the patients before we even meet them, they have their screen, and we're already starting to vaccinate them, at the first discussion or even before they even come to their first clinic appointment, so that we actually can, if it's possible, get them vaccinated before we start them, if we've got time to do that.
Yes, it's been
I'm
interesting.
Thinking about live vaccine. I'm talking about live vaccines.
Yes.
Obviously, you can give them non-live vaccines, but it's the live vaccines.
Yeah. And we're getting some more choices around that with the zoster. So it's been interesting tonight to think about the discussion around the lymphoma risk and guidance on what to do, particularly if the male is EB negative. So it's been interesting that this has been a bit of a focus tonight. But one of the questions that we had been asked previously, and Jake, you touched on this a little bit, is around decisions you might make in an older patient and choosing the biologics in that setting, where often there's not the evidence to guide that decision. Is there any further comments you'd like to make on that at this stage before we come to a close?
I would just make two brief points. One is that the decisions on the biologic therapy are based on the severity of disease as well, not just the patient's age. So we shouldn't be age. But that being said, we should consider some of the side effects of some of these agents and what that might imply in an older individual. So all things being equal, in patients who have moderate end of the spectrum of disease, I'm looking for agents that have the best side effect profile for those patients. But in patients who need anti-TNFs, for example, because they have severe disease, then I'm using it for sure.
Thank you very much. And Susie, is there any last minute comments that you would like to make before we wrap up this webinar?
I was actually thinking about the screening things. I don't know, Jake, if you do CMV, because I actually do CMV as well beforehand. The reason I do it actually is then when the patient then has it, is that later on when they get, it's just this issue of was it a primary or secondary CMV? And we always these arguments with ID about whether or not their immunosuppression actually affected their ability, they're getting, because it influences potentially decisions around do they continue their thiopurine subsequently if it was primary CMV, which apparently is not necessarily associated with immunosuppression. I understand. I might be wrong. That's the discussion we've had with the ID physician. So that's the reason I checked CMV as well, IgG before. Most of the time they're positive already, but it's just in those cases where they are. It doesn't influence you, you know, in terms of, it's not going to make you more worried about anything. It's just sort of an educational thing. But it went for subsequent, you know, if they get sick later with, you know, primary CMV potentially. There's an extra, it's not really, yeah, just another point. I don't know, there's nothing else really in terms of the elderly. Jake's really said it all, essentially.
Thank you very much.
And the other thing also is trying to limit steroid use in older patients. And biologics are far safer drugs than steroids are. And I think we need to, you know, everyone needs to remember that.
I think,
yeah.
Thank you very much. And I'd like to thank the panelists very much for, you know, a very stimulating and insightful discussion this evening. There are a number of resources that have been developed as part of this program, and they'll be available, plus the webinar slides. And as I said at the start, you'll receive links so that you can access these resources and use them in your practice. We'd also really appreciate if you could spare some time to complete the survey that will pop up at the end of this webinar. And as I said, you'll receive participation certificates and they'll be sent to you via email. So again, I just really like to thank everyone. This is a very important area of practice and we really appreciate the insights that you've shared with us tonight, because there are uncertainties. We've got the best available evidence, but then how do you translate that into your practice? And Susie and Jake, you've shared with us your experience and it's been very much appreciated. So thank you very much, and we'll close the webinar now. Thank you.
Thank you very much, Deb and Karen for all your hard work.
Thank you very much.
Thank you.
Pleasure.